and we just reported on the first 3 subjects, that AAV gene transfer to the retina is safe. There were no consequences, deleterious consequences of surgery. There was very little inflammation. And what we could demonstrate was that there was a significant improvement in retinal sensitivity that we could demonstrate not just by psychophysical tests of vision in the laboratory, but also by testing patients' night vision in a maze. And many of you will have seen the video of the patient Stephen Howarth, who was able to walk through the maze after treatment. I'm not going to show that because I think it's been seen so many times. I really want to emphasise where we've gone from that initial report. Well, the first phase involved 3 young adults with advanced degeneration. The second phase, which you've just completed, involving 9 subjects, included a dose escalation with subjects as young as 5. Subjects with null mutations, and there was no restriction on visual acuity. Some of the patients had quite good visual acuity and very little in the way of degeneration. So we were expecting the treatment to be even better in these subjects. And what do we see in the phase 2 study? Well, the details of this will be published soon. We're just writing up the paper, but we can see that there have been no adverse effects to date. There was some mild inflammation in 1 subject, but we saw improvement in another 5 subjects. Not all of the subjects had improved retinal sensitivity. What was, I think, very interesting was that despite the improvement in rod vision, night vision, we didn't see any changes in visual acuity or ERG. So essentially, the therapy is not working as well in our trial or that of Bill or Jean's RP65 trials as well as it is in mice and dogs. So in the short term, as we discuss what we're doing next, is we're now establishing a second trial for the RP65 defect. So we're now making an improved vector, and we hope to start a new trial in 2 years' time. In the medium term, what we're doing is we're developing treatments for other severe early onset disorders, but it's important to emphasise, even if these treatments are successful in terms of a clinical trial, it's going to be a long time before these therapies are going to be widely available and have major clinical impact. We're still at the stage of demonstrating proof of principle in patients. So my talk is about the Moorfields pipeline, and that's what I'm going to finish with. What we're concentrating on now is establishing proof of principle for other types of inherited retinal degenerations, not just RPE defects. Most inherited disorders arise from mutations in photoreceptor-specific genes, and so we're now trying to establish proof of concept for these types of disorders. And we have demonstrated a number of proof of concepts in animal models for other forms of LCA that are caused by mutations in photoreceptor genes, and I've listed some of those, including ARPL1 deficiency, the GUCY2D or RETGC deficiency, RP grip deficiency, and we're in the process of developing gene therapy approaches for other forms of LCA, including RDH12, and that's in collaboration with Deborah Thompson, and CRB1, which is LCA3, that's in collaboration with Jan Winholz in the Netherlands. But we're also, as well as LCA, which is the most severe form of inherited disorders, we're also establishing gene therapy for other early onset disorders. Again, they're all early onset. That includes achromatopsia, which we're very interested in, and gene therapy for X-linked RP, which is a juvenile onset disorder. And in summary, we've established a pipeline for at least 11 forms of early onset retinal dystrophies where we've published the proof of concept. But we can't take all of these we can't take all of these into clinical trial. That's 11 single gene disorders that we could attempt to treat in the clinic, and that's too many for any academic group to take into clinical trial. So we've got to focus on a number and prioritise them. And our strategic focus will be on cones, and that's because loss of cones has the most pronounced effect on quality of life. And so we've been focusing on gene therapy proof of concept in animal models of cone and rod disease, either cone only or rod cone disease. And I'm going to just, in the last couple of minutes, 5 minutes if I've got 5 minutes, Mr. Chairman. Do I have 5 minutes? If I have 5 minutes, I'd just like to tell you about the proof of concepts that we're now aiming to move into clinical studies. So first is achromatopsia, or stationary day blindness. Here we have an absence of cone activity from birth. Patients have very poor daylight vision, very poor visual acuity, lack of colour vision, and extreme light sensitivity or photophobia. But it's a very stationary disorder, which creates opportunities for intervention. And there are a number of forms of achromatopsia, but the most common form is due to a defect in CNGB3. And we have a mouse model, a knockout mouse, that lacks CNGB3, and we've shown that if we use gene therapy, we can treat this model very effectively. We put the missing gene back into the cone photoreceptors, and we improve both the electrical function, it's measured by ERG, and we can show that this is very stable, that persists for 9 months, which is as long as we've looked, which is a long time in a mouse. And even very old animals can be treated successfully if we treat a 6-month-old mouse. And we also have shown that we have not only improved the retinal function, but we've improved the vision as measured by head tracking. So whilst we demonstrated proof of concept in this stationary disorder, what we also want to do is see whether we can use gene therapy to halt cone degeneration in a progressive cone dystrophy. And the example I'm going to show you is another form of LCA caused by a defect in GUCY2D, or the RET-GC gene. And this is a gene product that's present in both rods and cones. And it's the defect, loss of function mutations, cause cone and rod death in the first decade of life. So it's a very severe condition. It's an LCA. It's one of the most common form of LCA, about 13% of all LCA. And again, we have a mouse model, and we can show that we can restore the missing gene product to rods and cones, shown here. We can improve the retinal function very effectively, both rods and cones, measured by electroretinography, and we improve vision as measured by head tracking. And not only that, in this case, which is most critical, is we slow the degeneration very substantially in treated animals. 6 months after treatment, we've got very, very substantial preservation. So the viral vectors we're using are able to transfer genes to cones. That gene transfer can lead to improvement in cone function, and in both stationary and progressive disease. And in progressive disease, we can slow the cone loss. So we believe that cone diseases are going to be very good candidates for future clinical trials using the technology we have available now. And one final example I want to show you is gene therapy for X-linked RP, which is the most common form of retinitis pigmentosa. And again, we have a knockout mouse model that lacks the gene RPGR, which is mutated in most individuals with X-linked RP. And this is a model generated by Tianson Li, our collaborator at the NIH. And using gene therapy, we can put the missing gene back into the rods and cones, and we can restore the structure of the light-sensing cells, both rods and cones. You can see that treated animals have much better rods and cones. And importantly, we improve function, But most importantly, you can see here, in mice that are 2 years old, we still have very well preserved photoreceptors compared with the untreated animals. So this is a very important target for us because it is so common. The clinical trials are rather difficult, but we aim to work up for this. So in conclusion, what we've shown is that gene therapy can be safe and is partially effective for treating patients with RP65 deficiency. I believe that improvements are required in order to obtain an RP65 vector that will be really effective enough to be licensed to be given as a treatment in clinics. But we're on our way to that, and I believe in a few years we will be in that situation. But experiments in mice and dogs suggest that other forms of retinal dystrophy may also be amenable to gene therapy, and that's the case for both cone and rod disorders and for progressive as well as stationary disorders. And soon there are going to be more gene therapy clinical trials that will tell us how these animal studies are going to translate into the clinic. But as a warning, and I think just as a thing, this slide shows our timelines. We started gene therapy in 1994, and we're here now, where we've completed our first trial, we've been planning our next trial, and we're going to start our next trial in 2013, probably towards the end of 2013. And that will be for CNGB3. We've started to make clinical grade vector, we're putting in the regulatory applications, we've identified subjects.